Hello online, can you all hear?
I heard you loud and clear there.
Perfect. Okay, let's get going real quick. Sweet. This is another quick one, so we'll try and get as much out of it as possible. Any questions, please let me know. Online world, please chime in. If you guys see them, let me know because I tend to miss it. So we are going over face and neck injuries today. It's a pretty confined area, so there's only so much to talk about. This isn't working, Chief.
Click.
Oh, we gotta click into the PowerPoint, huh?
Now try it.
There we go. All right.
Who solved your problem?
You're the best, Chief. All right. So we're gonna go over diseases of the eyes, ears, nose, throat, and then some injury patterns to the neck. We're not getting too deep into the brain or actual spinal column. That's another chapter that you guys are covering, but we'll kind of skim the surface of some of them. We'll touch on some traumatic things, a lot of medical stuff, and then the end kind of wraps into some trauma. So this is mostly going to be recognition of life threats. There's only so much we can do to a lot of these areas, but we'll kind of cover the physiology behind them, and then hopefully we can get ahead of it. So we'll go over penetrating neck trauma, laryngeal trauma, spinal trauma, and some facial fractures. See you, Shay. We'll touch on some pathophysiology, and it gets into this more later, so let's get going. Soft tissue injuries and fractures to bones are common and in different severities. So if you're suspecting more facial fractures, expect more spinal injuries and more intracranial problems. It takes a lot of force to, not necessarily the nose, but it takes a lot of force to break a lot of the rest of the bones in your face. And a lot of that force is transferred to the rest of your cranium during that time. So keep that in mind, especially when you get into high cervical fractures. A lot of it is just due from the pure force when they hit their head on whatever or get hit. One of the number one causes of the C1, C2 fractures in the geriatric population is a ground level fall, just because of how they hit. So just keep that in mind. Some injuries are life-threatening. A lot of the life-threatening injuries are going to have to do with either A, if you hit the spinal column, or B, if you interfere with your airway. So most of this actually denotes to protecting the airway in these chapters. Most of this is just going to be injury prevention and then managing the airway, like I just said. There's going to be a lot of control and cover. There's, once again, only so much we can do for them. So here's a quick AMP review. Your head is divided into your cranium and your face. We're strictly going over face and neck today, so everything behind your facial bones, where your brain picks up, is going to be another chapter, but you guys can look over the graphs here real quick. You have your zygoma and your maxilla and your mandible, and then your nasal bones, and then we'll travel all the way down through your spinal column here. This is your larynx. So online world, sorry, you're not going to be able to see this as well, but you guys aren't going to be doing crikes, but if you're going to do a crike, this is the membrane that we're cutting, which is good for review. The top piece is a little bit manipulable right here on the cricoid or the thyroid cartilage. If you guys feel down on your neck, there's actually a hole right in between it. That's your cricothyroid membrane. It feels really small, which is why we're passing such a small tube through it. If you get into a situation, you're helping one of your medics and they're having trouble passing, you can actually lift that up a little bit by manipulating the head, depending on whatever caused their injury, whether you can lift it. But that's actually where you're aiming. All around there is a lot of muscles and vasculature, so be really careful within the rest of your neck. Everything on the lateral sides is mostly going to be vasculature and muscle. So if somebody's complaining of lateral neck pain, it's usually more of a whiplash situation. This is your eye. There's a lot of little pieces that make up the eye, and I'm not sure exactly how far your guys' test gets into it. Know that you've got a lens on the outside, and know that the retina comes back along with the optic nerve. Stroke patterns, there's the 12 cranial nerves. The optic nerve is one of them. So theoretically, if somebody was having a stroke, they could be interfering with just their optic vision as opposed to like a paralysis on the left side. It just depends on where their injury is. We will touch more into injuries on this later. I don't want to get too deep into it right now. Inner surface of the eyelids is covered by what's called conjunctiva. Have you guys heard of conjunctivitis? Really popular in dogs. It's just a inflammation of the conjunctiva. Dogs get this a lot when there's allergens in the air. They'll get kind of weepy eyes and things. But it's usually relatively harmless. They can treat it with some eye drops if it gets bad, but it's not usually a big deal. And then opening of the center of the iris is the pupil, obviously. And we'll touch on pupil changes later. Here's the anatomy of your ear. As you get deeper into the ear, it becomes more hard bones. Kids like to shove stuff in their ear, and if it gets much past right in this auditory canal, we really don't want to be digging anything out of there. If you can't see it and grab it with tweezers, you should probably just leave it alone, just because we don't want to damage anything else or push it in further. This piece here is your eardrum. This is actually really painful if it gets damaged, and not uncommon in especially peds, but also in adults. These patients will have increased issues if they are flying or anything like that because of gas laws. All that pressure will change. So if you pull somebody who's been on a flight recently and their ears are hurting worse, it's probably because of that. Yeah. So direct injuries to the nose and mouth are going to cause you airway issues. That can lead to obstruction, especially in people with dentures. Always assess their mouth and see if there's any teeth missing. And then the swelling that goes along with that is going to cause you issues as well. So we had a call a few years back with a lady that got stung on the tongue. Because it's such a soft tissue area, she wasn't allergic, but it ended up swelling and took up the bulk of her pharynx. The only reason she ended up okay, because she was refusing to let us intubate her despite our pleas, was that we had put an NPA in early and it was able to get behind her tongue before it swelled up. So try and get ahead of things. Think about what's going to be changing. Some more soft tissue injuries for you. Face and neck are extremely vasculature. They're going to bleed a lot. We don't appreciate head wounds enough in EMS. So if you put somebody on a backboard and you start traveling, try and get control of those. A lot of these people will actually lose more blood than you expect. And then it becomes a problem for the ER because they're behind the 8 ball. And then once again, any big injuries to the face, suspect that they're going to have more severe injuries underneath. This is a good point. I think Max and I dealt with this the other day, actually. So if somebody's swallowing a lot of blood, that's a big gastric irritant. They're probably going to get an upset stomach and likely vomit. So the more blood we can keep from draining down their pharynx, the better. And then also it's going to be a bit of an airway obstruction in traumatic situations. So try and keep that in mind as you're dealing with a lot of these car wreck patients. We tend to just put them on a board, but if we can get them positioned to where a lot of that's going to flow out of their mouth or into a KED, it's going to be better for them. I think we pretty much talked about this already.
They're asking that if you go to a screen to show something, you would use the TV above the computer. And I'm trying to zoom in on that a little bit.
Oh, okay.
So point to something on that TV.
Perfect. Sorry.
Yep.
Facial bones are going to absorb a big energy of all your impacts, especially when you're talking about car accidents. The nose is going to take a lot of it first and then get into the zygomatic areas, and we'll touch on some of these injury patterns later. But they're just really repetitive that your face is taking a big blow here. Nasal fractures are characterized by swelling, tenderness, and crepitus. Most nasal fractures are going to be lateral fractures. The first initial half of your nose is all cartilage, so it fractures really, really easy. After that, it becomes more of a big deal when you get into the bone area. As you get it more into the bone area, you're also going to have more posterior bleeding, and more posterior bleeding is a lot harder to stop, and they bleed a lot more. Most of that blood's going to end up in their pharynx, so it's going to be a lot more management for you on trying to keep them leaning forward and suctioned. Let's go back to this real quick. Most nosebleeds that we see are anterior. You'll see a lot of people that say they've been bleeding for an hour, 30 minutes. But the problem is they're taking pressure off of their nose. So there's some of the new standards I've read is if you can convince them to hold pressure on their nose and sit down and watch a sitcom for 30 minutes, bulk of them will stop, pending they don't have other factors like blood thinners or a big injury, which we should be able to figure out on scene. The bulk of these are going to stop. If they go to the ER, there's a couple things they can do for them, including cauterizing, or there's a nasal spray called Afrin that works really well. I don't know if the ER is still using it or not. They used to use a 10% cocaine jelly, just because it kind of constricted up the arterioles. But like I said, the bulk of these we can stop at home. The problem is most people just don't give it the time, and they try to recheck and recheck and recheck, and it just opens back up.
We're going to talk about adding Afrin to our protocol for the second protocol update through the end of 19.
Awesome.
We're going to do a real quick protocol update for sucks here real quick. But then the big protocol update for this year will be near the end, but we're going to try to add Afrin. Awesome.
Did you guys hear that online? Chief said we're possibly adding Afrin to the protocols at the end of the year, which will be stellar for our nosebleed situations. It works really well, actually. Mandibular fractures, so your bottom jaw, most of this is going to be a blunt trauma situation, and usually you end up with a fracture at the corner of your jaw, or a dislocation. Some people have kind of a congenitally natural bad jaw, and they'll get some popping in their jaw, especially as it wears down over time. But as far as the acute setting, this is where most of your injuries are going to be, is just disconnects. These are called the fort fractures. They're really difficult to manage. The first one is a Lefort 1. This breaks your maxilla right here, so you end up with a free-floating maxilla. It ruins most of your structure for ventilating and leads to a lot of ventilatory compromise. If they're going to get intubated, they're really difficult to intubate. It's doable, but because there's no structure there, it's just kind of floating around getting in your way. Lefort 2 comes up over your facial bones and then into your nose area. This includes the maxilla as well, so this whole area ends up kind of floating. Really painful for them, and obviously a lot of force to cause it. And then your Lefort 3 travels across your orbits. You can have a mix of all three of these. So you could have a 1 and a 3, or a 1 and a 2, 2 and a 3. They're, like I said, there's nothing a lot that we're going to do for them other than supportive care and management, but they become very difficult to intubate if their situation progresses. And if they had that big of a hit to their head, they probably have something intracerebral as well. Excuse me. Orbital fractures tend to lead to double vision. You can get a paralysis of the eye to where one of them is not moving. And a lot of these people, just because it's going to make them kind of sick, you can cover up both eyes and just let them live in the dark for a little bit because it makes them sick otherwise. They'll lose some sensation, and then they'll end up with a lot of nasal discharge. Something it doesn't touch on in here, and I'm guessing you guys are going to get into it in your in the next chapter that gets into a lot of head and spine stuff. They don't talk about basilar skull fractures. Do you guys remember that from your EMT class? Yes? No? Okay. So basilar bone is the bottom bone in the portion of your skull. It gets fractured pretty easily in situations like this. It can lead to a lot of cerebral spinal fluid coming out your nose and your ears. So there's something called a halo test. Do you guys know what that is? Yep. Yep. Yep, exactly. So you take the 4x4, you put it in, pick up some of the blood from their ear or their nose, and it'll actually leave a cerebral spinal fluid ring around the outside of the blood. Gives you a pretty good indication that they've cracked the basilar bone. It's not a guarantee, but it's common. Most of them are left untreated, and they just heal over a month or two. But they also, once again, lead to a lot of potential for other injuries, so we just need to be aware of them. You also can end up with raccoon eyes and battle signs. So raccoon eyes are the big dark bruising around their eyes, and then battle signs will be a bruise behind their ear. And it doesn't get into that here either, but it's worth mentioning. Zygomatic fractures are fractures of your cheekbones. So after you take out the nose, your cheekbones are next in line. Common in car accidents. But once again, it takes a lot of, or like a baseball bat to the face. It's common. Kids get these a lot when they're playing around with golf clubs or bats and somebody steps in the way. Dental injuries, we should probably do a better job of assessing for these than we do. Especially if you lose a tooth, if you can find it, that's great, but any fractures in there can cause airway obstructions. So in a lot of our unconscious patients, we should probably do a better job of checking their pharynx, especially if we're going to put them on a backboard and put them in a supine position. My opinion, whoever is at the head, whether they're being ventilated or not, is in charge of the airway, and they need to own the airway. So if you get stationed in that position, then it's your job to suction them as needed, and it's your job to control that, especially while everyone else is doing other things and sidetracked. We're getting into scene size up again. So I think you guys are all pretty good at size up, honestly, but consider how the mechanism of injury can affect the patient. Try and expect what you're going to see down the road, not just right now. Honestly, we do this a lot, especially with all of our refusal patients. We're trying to make sure that nothing else is going to happen, so we're pretty well practiced in this. Wants to touch again on using PPE and BSI, and then just assess any other hazards. So focus on your life-threatening conditions first. ABCs, check your ABPU. Once again, the airway, suction any blood, fluid, vomit in the airways, make sure it's clear. Whoever is in that position owns it. Especially if it's a bad trauma, whoever your medic partner is probably going to be busy otherwise, and I fully expect that you guys are capable to handle that on your own. If you're waiting for a transport unit or there's no medics on scene, then it's still something you can do while they're in the car, before you board them, after you board them. It's very basic, but it's very important. So it's another situation where the kid, as much as they're kind of a pain to set up, is a great situation to keep them in a good position. So just consider it. If they have any teeth fragments, you can remove them. If their dentures are easy to remove, you can pull them out and set them aside. Definitely don't want them getting in the way. If they're pretty well intact, there's also no problem leaving them for the time. So investigate their chief complaint. Try and think about your body systems. Just because they're complaining of one area doesn't mean that's the only area. So as an example, if they're complaining of shortness of breath, that doesn't mean it's not related to their heart. If they're complaining of a headache, it doesn't mean that they didn't have a spontaneous bleed, even if there was no trauma associated. So keep these things in mind. Sometimes I know we have a lot of people that say this is the worst pain they've ever had, but if somebody's saying that this is the worst headache they've ever had in their life, just believe them, because it could be an aneurysm. It's not one we want to get wrong. Secondary assessment, so after you've done your primary, they don't want you getting too deep in this book on scene. They want you to do your quick rapid, then get them in the ambulance, and then secondary, really get into your injury patterns and see what else is there. Obviously check the back before you put them on a backboard, and then checking for your decap, BTLS, everything else in the bus. We talked about this last week or 2 weeks ago when I was here. If it's a trauma situation, there's really nothing we can do for them as far as long-term healing. They need a surgeon. So the quicker we can get them to the hospital, the better, and whatever we can get done on the way is what we get done. And that just is what it is. Sometimes there's going to be some things you have to manage on scene that's going to better them in the acute setting. But if we spend a lot of time on scene trying to manage stuff, we're just wasting time that they could have a whole trauma team working on them. Obviously, if the patient is conscious and has an isolated injury, we don't need to do an assessment on everything else. Just be aware, once again, of your body systems and make sure you're covering what you need to. This is actually a good way to assess the face. So they want you to assess alignment, poke and prod, feel the nasal bones, see if everything's aligned. The nose is actually a common one. Like if you feel my nose, it's not aligned, and it's because I've broken it before. But that should be something that the patient knows. So if they're alert and they can answer those questions, then that should be a quick checkoff. But everything else still should be really stable. Shouldn't move around, shouldn't float. There shouldn't be a lot of pain. If there is, then you can start assessing that area further. Assessing their circulation. Obviously, we're going to get vitals on every patient. Assess their perfusion, and then glucose levels on anyone that's altered. Even if we think it's trauma related, sometimes we need to figure out why they had the traumatic event in the first place. So don't write it off. Also be leery if they have a traumatic situation. Be careful with any D50s and things because it's so corrosive. So their sugar can't be low, but you also don't want to pump them up really high. So it's just going to be a balancing act. And then repeat assessments en route. Another thing I think in EMS as a whole that we need to get better at is assessing blood loss. We're not as good about guessing how much blood somebody's actually lost or taking that into consideration. So there's some ways you can practice this at home or in the station. It's probably something we should get better at so we can try and figure out exactly how much, not exactly, but a relative idea of how much they've lost. The further we appreciate that, the quicker the ER can appreciate the situation they're in without pulling blood labs. So once again, in head injuries, they tend to bleed a lot. We put them on a backboard and then most of the blood runs underneath them or on the pillow or a blanket, and we just don't give a lot of consideration to it. Soft tissue injuries can have a lot of swelling, which ultimately could impede your airway, but more often than not, this is going to be something very basic for us to manage. So cover any exposed areas that if it should be inside and it's not inside anymore, cover it with a sterile wet dressing. Everything else can be dry. I'm going to harp on it again, just really try and control that bleeding early. Get ahead of it, you can just check it off and be done. Broken teeth and lacerations can injure the tongue. Anything in the mouth tends to swell a lot. Tongue heals fast, mouth heals fast, but in the interim for us, they cause a lot of swelling, and then they become a lot harder to manage if we don't get ahead of it once they are swollen. Anything that becomes avulsed, separated, amputated, wrap it in moist, sterile dressing, put it in a bag, don't ever put it on ice, and just try and bring as much of it as you can with you, and maybe they can reattach it. So injuries of the eyes. Pupils are normally round in the general population, but not necessarily in everybody. If people can have abnormally sized pupils in general, they can also have abnormally shaped pupils. So it can be a good indication that they had an injury, but it can also just be their normal pupil. Most people, ironically, have no idea. It seems like every time I've asked, they've been like, oh, I don't know, it's my eye. So try and, if somebody knows, then great, and if not, just assume that it could be an injury until proven otherwise. They can be a sign of brain injury. They tend to be a later sign. If you're getting enough pressure to change your pupillary response onto your midbrain, then it's usually a big deal. So treatment starts with thorough examination. Try not to aggravate the problem. They don't want you touching the eye, but if there's something you can rinse out, then great. Anything underneath the upper eyelid, they say just to leave in place. You can try flushing, but leave it alone. Otherwise, you can see the swelling on the guy's eye on the left. That's not uncommon. And then broken blood vessels in the middle, and then he's got a foreign body in the third one. Another thing they don't really get into in this one, but you'll see a lot, just as your patients have it, is glaucoma and cataracts. So glaucoma is an increased pressure in the eyes that slowly causes a vision loss. They do have some drops that can decrease pressure, but it's more trying to manage the progression of the disease. It's not going to stop it. And then cataracts get the cloudy vision underneath the lens. So another one, people can complain of some minor pain if they have a vision sunburn. So a lot of people go up to the mountain if they're not wearing glasses or goggles, can get a minor sunburn. It's usually not too painful, but just something to keep in mind in your history taking. What have you been doing today? What do you do for a living? It's not uncommon to get Somebody was welding without their welding glasses, same thing. You can get a lot of burns. If they have, the other one, contacts. Hard contacts, they say you can remove with a suction piece. We don't have it, so they're going to be a little bit harder to get out. For those of you who wear contacts that are soft, they just pinch together and come out. Only take them out if they have a chemical or something in their eye that you're trying to flush underneath, because otherwise it can trap the chemical. Otherwise, they just want you to leave it in place. The other one that's important to all of us in here, if you wear contacts, is thermal injuries. So contacts are very thin plastic, and if you open your eyes too close to a fire, they can actually melt, and then they're stuck to your eye. So
with that, if you were trying to remove it, would you just be spreading the eyelid open and going in pinching fashion, or would you be trying to do the slide?
No, pinch and remove. And you may or may not have a lot of use with it, depending on how much they want to open their eyes at the time. Most people that are going to have, there's obviously home stuff where you get chemicals in your eye, but most commercial issues where they're going to end up with chemicals in their eye are known chemicals that they work with, and they have washing stations, but not everyone. So a lot of history on that. You can also take a nasal cannula, and you can hook it up to the saline bag, and then the two prongs that would go in your nose, you can rest on the bridge of your nose, and it'll actually run fluid down both eyes. You want to run from outside in. That way nothing gets pushed back into the eye. But that's a really easy way to set it and forget it, and then you can move on to other things. Yeah, that's what I'm doing. Sorry. I said it wrong. Inside out. If they have eye injuries, bandage both eyes. This prevents them from moving the other eye because they'll just kind of stop, so it reduces a lot of pain. If they get vision sickness, then they could also help with that. So. Here's your chemical burns. So this is an example of one of the commercial eye wash stations. You can also do this with a syringe, just the saline bottles in general. They want you to flush for several minutes. I think it says 5 in your book, but I would double check that for your test. Yep, 5 minutes. If you can irrigate while transporting, that's great, especially if you have a wash basin you can dump into so you're not pouring stuff all over the ambulance. But very basic still, they're going to be painful. We carry tetracaine, which will numb their eye. So after you get it irrigated, you can actually numb it up a little bit too, if you have a medic with you. These are different examples of chemical burns. To be honest, I would assume there's not a lot they can do for them, but I don't know. So after completing, cover the eye and transport. These are thermal burns. These are definitely going to end up in a burn center for further treatment. So try and think about that early.
It might be good too, if you only have one eye injured, just cover both eyes, because you have a tendency for the eyes to work in sync.
Yeah, Amanda is just pressing again to cover both eyes. As one eye moves, the other one's naturally going to move, even if it's painful. So it's going to worsen the injury and cause them more pain. So if you can just shut their vision down, it makes them a little bit anxious, but it'll decrease their pain. So once again, contacts. So a lot of people at bonfires and things or barbecues, your eyes will naturally close when there's a lot of heat coming, but if they don't get closed fast enough, that's such thin plastic, it doesn't take much to melt it. We talked about light burns already. Any lacerations to the eye need to be taken to the hospital. The eyeball can pop out of the orbit, in which case cover it with a sterile dressing, cover the other eye to prevent any further injury. It requires very, very careful care by an optic surgeon to try and restore some of the vision, if not all of it. And here's a couple more injury patterns for you. So this is, in cases of blunt trauma, there's something called hyphema. I've never seen this, but it would be kind of wild, I think. So there's, in the different layers of your eye, you can actually get a fluid buildup, and it'll kind of be like a fish tank in there. So they'll just have fluid in their eye. Displaces their vision a little bit, and obviously painful, but I've never seen it. Has anyone else? No? Orbit fractures, so anywhere around the eye can get fractured. It's going to cause eye pain. It can cause a little bit of paralysis if it hits the nerves or the muscles detach. Once again, easiest thing to do is just cover them, and both eyes preferably, and then you'll prevent further injury. You can see her pupil on the left is paralyzed up, so she's going to have double vision and probably get a little bit of motion sickness along with whatever pain she's feeling. Retinal detachment can be like I don't want to say congenital, but can be a injury that naturally happens over time. Your eye doctor will actually assess you for this during your vision assessments. She'll go through and make sure you're not having any retinal detachments. Does require urgent medical attention if it's an acute thing. Usually they're going to have flashing light specks or kind of little pieces of vision that aren't doing so hot. Relatively painless, but unless they had an injury that accompanied it. Once again, if one of their pupils is larger, suspect a head injury. They should have, in the bulk of situations, they should have other signs and symptoms pointing you to head injury as well, because it's a relatively late sign, unless it just hits perfectly. But assess for that. You can try and assess their pupillary response. It shouldn't be very good in the affected eye. Blast injuries, if any foreign body is embedded in the globe is the eyeball. So you can use a clean cup or similar to protect the eye. You can put, if something's sticking out, if it's a smaller piece, you can just cover it with a metal shield or gauze or something. Most people that weld have had small pieces of metal in their eyes. If they go get an MRI or a CAT scan or something, that's going to be something they need to know, because the MRI can actually rip the metal out of their eye, which would suck. So they'll get an x-ray first just to make sure there's nothing in there. This is talking about contacts. We kind of already covered this. Once again, if the eye's been injured, don't try and remove the contact unless it's a chemical situation. We already talked about nosebleeds a bit, anterior and posterior, remember. They usually originate from the area of the septum and bleed fairly slow if it's anterior. A lot of these patients too, just because of old teaching, have kicked their head back and they get a lot of clots that run down the back of their throat. Remember that that's going to upset their stomach, and it can lead to blood clots that they can choke on. So if you can, have them lean forward. And then a lot of it's just a waiting game, and it sucks being on scene waiting for 30 minutes to find out if something works, but you'll save them an ambulance bill and an ER bill and a long chart for you if you can get it accomplished. So if they're bleeding too bad, or you don't feel like it's going to stop, or you feel like it's posterior, then definitely just take them right away. We don't want to delay treatment. We just also want to be a good advocate for our patients. So. This is the anatomy of your nose. So you have the septum in the middle, and then you have what are called turbinates. Those are the three bony pathways within the nose. And then sinuses above it. So once again, if somebody has a sinus cold or sinus congestion, they go on a flight, due to gas laws, they're going to get a lot of pressure in their sinuses that gets trapped. It becomes a lot more painful. Case in point, a lot of the life flight guys say if they have a sinus issue, that they'll just call in sick. They won't even go to work. It's just going to be miserable all day. Pictures of epistaxis. So if we end up moving forward with Afrin later, this will speed up the process. Afrin works really well for those of you who have used it in epistaxis, and it's something you can get over the counter too. So if you guys have nosebleeds at home or have kids that have nosebleeds at home, it's an over-the-counter spray that is like $8 or something. Injuries of the ear tend to cause some kind of impairment. If you think about your 5 senses and then remove one of them, it messes with you in general. The ear has a lot to do with balance. So these patients get a lot of motion sickness, a lot of ear pain. They can bleed. A lot of it is, they can give them some things to help ease the healing process, or like an antibiotic drip, but a lot of it's just going to be a waiting game too for a couple weeks. So If part of the ear is avulsed, you can try and realign it. If it's completely amputated, then once again, put it with some moist, sterile dressings, put it in a bag and transport it. We don't want to remove any impaled objects from the ear or relatively anywhere for that matter. So try and stabilize it, keep them in a position of comfort, keep them away from leaning onto that side and transport. Don't try and manipulate any body that's in the external auditory canal. Anything that's in there, we can actually cause further injury. So like I said earlier, a kid sticks a quarter in the outside of their ear and you can grab it, that's no big deal. But if something's actually down into their ear canal, just wait and they'll get it out of the ER. Last thing we want to do is push anything down further or cause any more pain. This is a picture of a facial fracture. So you could have bleeding in the mouth, can have an inability to swallow, you can lose teeth, check for movable bone fragments. Once again, a lot of this is just going to be airway care, making sure that they're not choking, not getting obstructed. A lot of positioning. Obviously, we can try and control the bleeding, and we can try and get ahead of any airway issues, but other than that, a lot of this is going to be stabilizing and transporting. Facial fractures alone are not emergencies unless there's serious bleeding. They do need to be treated in a relatively short time frame if they're going to need a plastic surgeon. So it says 7 to 10 days. Dental issues can go a little bit longer, but if they're missing teeth and things, still, I mean, if they popped out a tooth, they can go to their dentist. But if they've got a bigger mechanism that caused it, they should just go to the ER and make sure nothing else got fractured. Not a lot. Some people that end up knocking their teeth out have knocked those teeth out before. So it's a good history thing for you, just to ask them. A lot of those teeth that get put in just get knocked out and then they go get put back in and it's not really a big deal. Oral and dental injuries typically result from motor vehicle collisions, baseballs, softballs, baseball bats, golf clubs. Common in car accidents, especially if you hit the dash, the steering wheel, or if they weren't wearing a seatbelt. Also common, like I said, in sports injuries. So kids will get them if they run through the house and they fall down on the coffee table. They can knock their teeth out. If they are severely bleeding in their mouth, once again, whoever is owning that airway is going to be responsible for suctioning them. A lot of positioning, and then just either they need to be intubated or they need to be positioned to where they're not going to have that going down their airway and down into their stomach. It's going to be difficult to apply any pressure to those areas, so it's going to be more, especially if they're bleeding bad, it's going to be a rapid transport and try and get them into the ER. Leave impaled objects in the face. And when dealing with an avulsed tooth, handle it by the crown and not the root. Injuries of the neck, like we talked about earlier, lateral injuries aren't as big of a deal unless they got into the vasculature. Anything in the cervical spine is obviously a big deal, and anything in the anterior neck is going to be a more bigger deal. Stuff in the larynx, in the thyroid, if fractured, don't spring back into place. So they will need to be either surgically repaired or realigned. You'll see in this picture he's got some bruising. You can check for trachea shift. If they have a pneumo or they poked a hole in their trachea, they can get subcutaneous emphysema. So I don't know if you guys have ever felt that, but you can feel around into their neck and their upper chest, and it'll feel like Rice Krispie treats. Just kind of snap, crackle, poppy. So it's something to take note of. It's going to swell a lot. One of the injuries that you want to get ahead of if you can. Injuries to the neck can lead to a loss of voice, difficulty swallowing, severe and sometimes fatal airway obstructions. Included in this is going to be just natural choking. So people tend to choke on things like hot dogs and steak and bread. And some of this we can pull out. Some of it is going to require intubation. They're just going to push it down depending on if they can get to it or not. We don't want to do blind finger sweeps, but if we can get in there, if you have your medic, you can get in there with the McGills, or if you can get in there with some suction, you can clear a lot of this out. People that tend to choke on things, I don't know if they just don't chew or what, but they tend to choke again. So I don't know why, it just is what it is. But this is talking about that subcutaneous emphysema we just talked about. They should probably have some other indications that something's wrong before you see subcutaneous emphysema. But if you do find it, it's kind of a cool sign for us, and it does solidify our suspicions. Anything in the neck that caused a throat injury can also cause a cervical spine injury. So think about your mechanisms of force. As it travels through, the force doesn't just stop the second it hits your neck, it's got to continue somewhere. So if they have a face injury, if they've got a neck injury, assume they have a spinal injury also. Penetrating injuries to the neck can cause profuse bleeding. I highly recommend, if it's not in your book, that you guys all look up the vasculature of your neck. There's a lot of vessels running down both sides. Very important to know where they're at, and very important to recognize that they are big vessels that you can bleed out from really quick. After you guys are through here, you'll be qualified to do EJs. So we don't do them enough anymore. It's a big line, and because of IOs, we've kind of let them go by the wayside, but it is a phenomenal place to get a gigantic large bore IV that you can just flow fluid through. So keep it in mind, if you have them turn their head and run down the side of their jaw right here at the mandibular angle, it tends to run right here. So there's other vasculature in there as well. You want to be aware of it, and you want to know where it is so you don't get into the wrong vessel. But it is a big vessel that when everything else is not available is a great option. Injuries to the neck can lead to a fatal air embolism, which naturally makes sense. Keep in mind, everything you do near the neck is a direct route to the heart and then subsequently to the lungs. So keep that in mind. Seal any open neck wounds with an occlusive dressing, and then it's going to be more difficult to apply pressure to these wounds because you also don't want to be cutting off pressure to their brain. So it doesn't take much to decrease the pressure in your carotid arteries that's feeding your brain, but you also need to get pressure on the wound. So it's going to be a balancing act, but definitely the occlusive dressing, and definitely try and get pressure on it early. And then a rapid transport if they're actually bleeding from their neck. Apply pressure above and below the wound if it's a knife wound or somebody got a pencil stuck in their neck or something. Then it should be a relatively small area that you can actually occlude above and below. If it's a bigger injury, that might be more difficult, but you guys can assess that when you get there. Laryngeal injuries tend to be blunt force. Once again, it doesn't spring back very well. So just keep in mind that anything in the larynx can cause them big problems. Penetrating objects, this is one of the only ones we can remove, and we can only remove it if it's interfering with their ability to ventilate, specifically doing like CPR and things. So if they are blocking the airway, then you have to take it out. It just is what it is. Try and put an occlusive dressing around whatever you remove, save whatever you remove, and then transport rapidly because they probably need a surgeon. These are signs and symptoms of larynx injuries. Seems relatively straightforward. Are there any questions? Do you guys want a break? We've been going for a while. Good? Okay. To manage a laryngeal injury, provide oxygenation and ventilation, apply a cervical collar, be alert for their need to suction, and don't delay transport. Once again, your guys' book's very repetitive on a few things. One of them in this chapter is making sure that the airway is not obstructed. Most non-penetrating injuries are classified as sprains and strains. Do we know the difference? Online world, anybody want to chime in? What's the difference between a sprain and a strain? Let's see if online wants to chime in. I'll call on someone. Okay. Ryan, what's the difference between a sprain and a strain? Good job. Nothing much different that we're going to do for the differences in those, but it's a good thing to be aware of. A lot of lower back issues tend to be a sprain and not necessarily spine or bone related. Same thing in your neck. Anything laterally is going to be a whiplash or a sprain, or a strain, excuse me.
Just got a question from Matt Church, ligaments versus tendon.
Yep, perfect. We just asked about that. So it's going to be ligaments versus muscle, but cool. Pre-hospital management is going to focus on preventing further injury and making sure that they stay immobilized. Essential to check your distal pulses. It's another thing that we probably should be better at, is reassessing our PMS, not only right after we immobilize them, but as we go down the road. If you guys carry a pen or a Sharpie, it'd be really handy for you to mark pedal pulses, mark radials, and anybody that you immobilize. That way, if it does disappear, you know where it was. It makes it really easy to find it later. So especially in car accidents and things that we go on, if we immobilize them and I've got a pen, as soon as I check their feet, I just X their pedal pulse and then we're done, move on. Helmets, face shields, mouth guards, and safety eyewear obviously prevent injury. That seems straightforward. Any questions? Perfect. We're done. Questions? Questions? Online questions? It's a pretty basic chapter. So, okay. Have a good day, everyone.
Thank you.
You just pause the recording.